All right, the chair detects a quorum. Madam Clerk, please call the roll.
Representatives Baum, Camper, Freeman, Gant, Hawk, Hazelwood, Lynn, Ogles, Todd, Whitson, Williams, Wendell. Chairman Hicks. Chairman, you have a quorum.
Thank you, sir, and I apologize for that. I mean, Mr. Clerk, apologize. All right, good afternoon. I'd like to begin by welcoming everyone here to the Finance, Ways, and Means Subcommittee. Certainly look forward to working with everyone this year, and I look forward to the first year of the 112th General Assembly, especially as it pertains to this committee, and I certainly appreciate the opportunity to work with the members and staff of this committee as we work through legislation that finds its way on our calendars. Now, members, we will spend more time on introductions and review of our policies and procedures in our next meeting, but for now, and in the interest of time, we will now take up our calendar. So, with that said, item number 1 on your calendar is HJR 18. Leader Lamberth, you are recognized. There's a motion and a second. Please go right ahead.
Thank you, Mr. Chairman, and again, thank you for your leadership on our fiscal responsibility here in the great state of Tennessee. I stand ready for questions. I know that all of you have had an opportunity to read over this very short resolution. This has been a multi-year process that we've all been embarking on, in which we now have an opportunity to really take advantage of a shared savings plan. This began as a block grant proposal that we sent to the feds, and they have sent us back a carefully negotiated win-win scenario for every Tennessean that is a shared savings plan. So we will be able to leverage the savings that we are currently gaining in the way we run TennCare to the benefit of all TennCare enrollees. And potentially that can mean an expansion of services for TennCare recipients, and even potentially to be able to clear some of the wait list on folks that are currently eligible, such as those that are adults with developmental disabilities. So, Mr. Chairman, I stand ready for questions, and there's an entire team here from TennCare that are experts in this area and have been a part of this negotiation. They stand ready for questions as well.
Thank you, Leader. And members, if you do have any questions, if you'll just let us know, we'll certainly get you on the list. Are there any questions at this time? Chair Lady Hazelwood, you're recognized.
Thank you, Mr. Chairman. Could you just, for the record, help us understand how those potential savings might come about and the mechanism for utilizing those? You mentioned developmental disabilities and some other areas. So could you just elaborate on that a bit, please?
You're recognized.
Thank you, Mr. Chairman. And I will attempt to do so. And if there are more detailed questions that you would like to have from the folks that are actually doing this every day and have helped gain those savings, I will be more than happy to step aside, and Mr. Chairman would recommend that we go out of session for those folks to answer those questions. I would like to ask at this point, would you like me to make an attempt at answering that, or would you like to hear from them, Madam Chairman?
I'm perfectly comfortable listening to your answer, Mr. Leader.
Yes, ma'am.
You're recognized.
Thank you, Mr. Chairman. So at this point, the way we would gain those savings is to continue to run the TennCare program the way we have been running it. There are savings that are within that TennCare has been able to accomplish where we run it better than what other states do. And so as part of that money right now is simply just going unutilized. It either remains in the federal coffers or it is just not being utilized. Now, there are opportunities for us to increase the health of the population that's being served by TennCare and potentially gain savings through that in years to come. There are opportunities for us to actually run the program better. There are opportunities for us to be able to negotiate certain savings with companies that contract with healthcare. There's lots of different ways that we can both continue and begin some additional savings with TennCare. Now, the way that those would be leveraged, and I'm going to give just kind of a overview of some of the initial priorities that we could go into with those savings. We could definitely, and there's a myriad of opportunities out there, but we could definitely improve maternal health coverage. We can enhance that health coverage right now that is already provided under TennCare, but we could do that at a higher reimbursement rate. We could provide additional services. We could do a lot that we're not doing right now for pregnant mothers and for both mother and child after that child is born. So that's one of the areas that we could expand into that really we're serving now, but we could do a better job on. there's additional needy populations that are out there. And one of the examples I've given on that is a lot of our local rural healthcare clinics and our rural hospitals could see some either additional programs or even better reimbursement rates to really target some of the healthcare issues that they have in those communities and do it on a much more targeted basis instead of a statewide basis where we know there's a problem, we know there's something popping up. For instance, dental care. I mean, there are some rural communities that have a real desert of options when it comes to dental care. That's something we don't cover right now, or at least not very much, and except in some of the extreme circumstances, that's something that could be an opportunity to provide some additional services for a population that desperately needs that. Not saying we will, but it's an option. We could clear the wait list, or at least do a long way toward clearing the wait list on adults with developmental disabilities. That's a population that's eligible right now for TennCare, and we just need some additional funds to be able to do so. That's something that I think would be a very, very beneficial usage of this money. And then lastly, and the list goes on, we could address any crisis healthcare need that pops up. And we would have the flexibility to do that here at the state level without having to pursue an additional grant of flexibility or exception to the current TennCare structure. And this would give us that flexibility here at the state level. So I don't want to belabor the point any farther. I don't know if I've answered your question. I've tried, but those are just some of the options that we could use those savings. And again, it won't cost us one more dime in our state budget.
Chair Lady Hazelwood.
Just one follow-up question. I know, as probably many of my colleagues, we're getting emails and calls from some of our constituents who are concerned about, and I believe this to be a misrepresentation, but I'd like to hear you speak to it. There is a concern that somehow this will cap enrollment or cap services or even take away some services. So if you could just address those concerns, please.
Leader Lambert.
Thank you, Mr. Chairman, and thank you, Madam Chairman. This in no way will cap enrollment or cap services. It just simply will not do that. That is why this is different than any other plan that has been approved in the country thus far. This is a first of its kind, but it can definitely be the model for how states could pursue this down the road. It's a win-win for the federal government and for the state government, and it is certainly a win for our constituents. But it is not a cap. It does not cap enrollment or services. It does have the opportunity to improve the services while the actual number of TennCare recipients fluctuates up and down as it does naturally. I mean, during tough times, obviously there are more folks that need TennCare. During good times, we normally see that enrollment go down. So it allows for that ebb and flow of the population and controls for that within here and does not cap that at all.
Chair Lady Hazelwood.
Thank you.
Thank you. Chairman Baum, you're recognized.
Thank you, Chairman Hicks. Leader Lambert, I'm interested in finding out a little bit more about how quality of care is incorporated in the proposal. I was wondering if you could give us an example of what would happen to the state and funding if the level of care, the quality level of care were to somehow fall or fall below an acceptable level. And then maybe the flip side of that, what benefit the state would receive if somehow the quality of care were enhanced or improved? Would there be a way for the state to gain additional savings beyond the current level of care?
Leader Lambert, you are recognized.
Thank you, Mr. Chairman. And the short answer, and we can go into this in more detail, is that if our quality of care were to decrease for some reason, and we hope that that would not happen, and all of us should keep a close eye on that and make sure it doesn't happen, but if it were to decrease, we get less savings. So we are financially punished, so to speak. We get less savings in it. Still have the baseline, still it does not affect our cap. We would still receive the kind of TennCare funding we're receiving now, but we would not receive as much shared savings as if the opposite is true, and the quality of care increases, which is what we hope to invest these savings into. And as that quality of care increases, the outcomes for those patients is better. And so because of that, we actually can get additional shared savings. I mean, it's kind of like there are plans out there throughout the country from time to time where a doctor will take on a set of Medicare patients, and if they are able to improve the health care and the quality of care, it improves their health overall. And many times there are some financial benefits to that group of individuals. With this, that looks at our entire state population. So if our quality of care were to fall and our patients are doing worse, then we would not get as much shared savings. And by the way, quite frankly, TennCare, and I makes them probably nervous for me to say this, would have to answer to us, because if the quality of care goes down, even under the current program, that's our job to keep an eye on that, both through this committee and GovOps and the TennCare Oversight Committee. But if the quality of care goes up, we have every incentive to make sure that it does, because we get additional shared savings that then it can be reinvested over and over again, and it's kind of a snowball effect that your patients are doing better. It should cost less, but instead of that cost savings just going to the feds, we keep it here to help additional patients.
Okay. Thank you. Leader Camper.
Thank you, Mr. Chairman. Thank you, Mr. Sponsor. I may have to go out of session for this question that I have, Mr. Chairman. If we get to that, I appreciate being able to ask Stephen these questions. Sponsor.
Chair Lady, before you begin, would you like to go ahead and go out of session so you can direct this straight to TennCare? Would you like to do that? All right, without objection?
Yes, sir.
We stand out of session. If you would just state your name and your position.
Thank you, Mr. Chairman. Stephen Smith, I'm the TennCare Director.
Okay, thank you. Thank you for being here. I appreciate it. Earlier, I was watching the insurance subcommittee today. I wasn't sure if we were going to get the presentation here, so I watched some of it today. And Representative Thompson asked a question about the people that had been added to the rolls. And it was something about we had 100,000 from this period to that period. Mm-hmm. And then because of the economic times and the pandemic, it grew another 100,000 people. And his question was around, if because of the virus and everything has taken place, and we have to add additional people to the rolls, is there a possibility that the outgrow of the coverage? Is there a possibility that we will outgrow this coverage that we're trying to offer now, or is there some inflationary things to make sure it keeps up with it? I didn't get a clear answer on that, and I thought maybe you could clarify that for me.
Sure, I'd be happy to. Okay. So we've got protections built into the agreement to take care of the very situation that you're talking about with the COVID cost. So one, we have a very advantageous base block grant amount for us, but then two, we've got that adjustment for enrollment increases. So as you mentioned, we've increased by about 7% since March of 2020, about 100,000 members. Mm-hmm. And so we've got a built-in protection because we get an adjustment to our enrollment cap for that type of enrollment increase. So it's not a fixed cap, it's a trended cap, but it also gets adjusted for enrollment increases. Furthermore, we have a provision in the agreement that allows us to go to CMS and get an adjustment if we have a similar situation that comes about in the future. So we feel like we've got all the protections in place that we need to address the very circumstances that you're talking about.
Okay, thank you for the clarification. So we can go back to CMS. Okay, appreciate that. The other question is around the utilization of the funds that we're saving, the shared savings. The sponsor mentioned earlier that we expect to have greater flexibility with the shared savings. So the question I have is, one, will those savings be reinvested back into TennCare? Can the department use it can it be used in the Department of Health in other areas, or do they have to go back into TennCare proper?
So we've committed that we will reinvest those funds back into TennCare or in areas that will provide additional benefits and services to TennCare members. So it's possible that there could be some initiatives that we would want to utilize those funds for that would be outside traditional Medicaid, but would still have a positive impact on the health of our TennCare members. That's the commitment that we've made.
Okay. All right. Okay. And so should that be the case, will we be authorizing that to happen automatically, or would the movement of these funds have to come back to this body to allow you all to adjust and move the funds around like that?
Well, these will be additional funds that will be part of the budget, so it will go through the same type of budget process that.
Okay.
all of our improvements do.
Okay, that was a question that I had. So you just talked about the savings can only be used for these programs, and I think that's it, Mr.
All right.
Unless somebody else had a question for
Thank
him.
you, Leader Camper. And just hold right there if you don't care, Director Smith. The next on our list is Representative Lynn. Representative Lynn, do you have a question for our guest, or would you like to speak to the sponsor? Okay, all right. You're recognized.
Thank you very much, and nice to see you, Commissioner. Our sponsor talked about if quality of care improves, and is that a reference to health outcomes? In other words, if we see the TennCare population or the populations with better outcomes, better health in some way, the metrics improve, is that what that's a reference to in terms of quality of care, or is that something else?
Well, I think it's two different issues. So the shared savings piece is dependent upon us meeting certain quality metrics, and so we will choose 10 quality metrics from this CMS core quality set. These are objective measures that all states have to report on, and so it's things like childhood immunizations or flu vaccines, cervical cancer screenings, things like that. But to the other point that the leader was making is that it's only to our advantage to make improvements in quality and health outcomes, because if we do that, that actually is going to lower healthcare costs, which will then generate additional shared savings, which we can then reinvest back into these areas. So it's kind of a circular thing that just benefits everyone.
You recognize.
Thank you. How do we measure the quality of care? And I have on my mind a young lady who works for me who she's on TennCare. She just really got out of MTSU, and she really was in a program to try to learn some skills, and we hired her, and I love her. I absolutely love her, but she's still on TennCare for a little bit. And she went to her gynecologist and was really unhappy with the service there. And I almost called y'all, and I asked her if she wanted me to call. I did. And she declined. But so how do we measure that? I don't know if there's any sort of patient satisfaction survey or anything like that, but I did tell her, I can look into that. I can. And, she's still a little shy. I think she's only been with us like 2 months. But how do we measure that?
That's a really good question. It's something that we've talked about as an executive team at TennCare, because I think most of the time when we think about quality, we're thinking about health outcomes, but there's also a piece of quality that's tied to the actual services, customer service that people are receiving. So one thing that we do is we have a survey that's of our membership that's conducted by the University of Tennessee every single year. And for the last 10 years, we've been above 90%. So I would compare that. I'd put us up against any other insurance provider out there. I think we're very proud of that, but we can always do better. But I know one of the things that we're focusing on, it's a priority for me, is to make sure that when we talk about quality, we're not just talking about the health outcomes, but we're also talking about the customer service that we're providing to our members.
You recognized.
And I have to say, I think TennCare absolutely provides excellent customer service, and so do many of the service providers, the physicians. And I think that this experience was, just the physician and maybe their bedside manner, I'm not sure, but something like that. And so that's kind of a hard thing. She did not blame TennCare. She blamed the experience. And I feel bad for her, and I told her, listen, we'll try to make it right, but I just didn't know what is meant by how do we measure quality. So thank you.
Sure.
Thank you, Representative Lynn. Chairman Wendell, you are next on my list. Do you have a question for our guest? All right, you're recognized, sir.
Mr. Smith, what is the projected savings in the first fiscal year if the General Assembly adopts this program?
Representative, I can't predict the savings. We have to get through. We have to get some experience with this. I mean, we do anticipate that over the course of the 10 years of this agreement that we will have significant shared savings. But I can't make a prediction about year one. Also, it's probably important to note that our greatest opportunities for shared savings are in the latter years. You can kind of look at this as 2 5-year periods because we get rebased at year 5. So if you look at the first 5-year period, probably years 3, 4, and 5 are our best chances because we get the benefit of the president's budget trend year over year, and historically we are below that year over year. So our greatest opportunity is not in the first year; it's in those later years.
So, assuming we use generally accepted accounting principles, has anybody in your department calculated what the savings is in year 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, or is it all to be determined?
Well, it is to be determined because we have to experience this. But if we look at our historical performance, then we know that we will have. I mean, we're confident we're going to have significant savings. What I can tell you is, while I can't guarantee you what the shared savings will be, if we don't do this, I can guarantee you the shared savings will be 0.
Okay. Just one follow-up, Mr. Chairman.
Go right ahead, sir.
Could you articulate in layman's terms what is the basis of your request to the administration for this block grant? If I'm explaining this explain it to me. I'm a layperson. What's the selling pitch on this? Because, I mean, you're a good guy. You're certainly a professional. I think you do a good job. You just testified that the quality of care that your department provides is in the 90 percentile or above. So that leaves single digits to improve. And the selling point is we're going to improve the quality of care, but you're already above 90%. So what's the selling point to Tennessee to adopt this? And again, you're a professional. Your department does a good job. You're always responsive. And this is not a aggressive question. But I think a lot of people are still unclear as to exactly what this block grant does. Can you boil that down for this committee? If somebody's listening in Cookeville, Tennessee this afternoon, I mean, what's the deal?
It's actually really simple. The ultimate goal of this is to be rewarded for our efficient management of our TennCare system and to achieve additional dollars that we can reinvest into our program. And we can do that without any additional expense on the part of Tennessee taxpayers.
Okay, just one final question, please. How much money is the federal government going to provide Tennessee if we accept this proposal from the federal government? Additional money.
Well, that depends on the shared savings. You're talking about additional money.
Is there a fiscal note for the federal government, or is that all a question mark too? I mean, is that, and I'm not being smart, but is that a mystery also about how much the federal government's going to give the state of Tennessee? Or is that a finite amount that we can put down in numbers?
I can't speak to the federal process of what they do in terms of fiscal impact.
Okay. That's all my questions. Thank you, Mr. Chairman. Thanks.
Thank you, Chairman. Members, any other discussion or questions for our guest, Director Smith? Chairman Hawk, you're recognized, sir.
Thank you, Mr. Chairman. Director Smith, thank you very much. We heard a lot of this morning. We do have a fiscal note, and it is it mirrors exactly what you've said several times through our committee, that it is difficult to quantify at this moment, but I do want to talk about a couple of aspects of the fiscal note that we do have before us. It says specifically, under the demonstration, the state may only expand benefits and coverage under this demonstration authority. Benefits and coverage cannot be reduced. I think there's some misinformation going on about that. If you could address that for this committee in particular.
Yeah, that's exactly right. We tried to make that point over and over. This will not result in any reductions in eligibility, benefits, services, what we pay our providers, and in terms of the benefits and services and eligibility, you actually see that in the agreement. It's in the standard terms and conditions.
And a follow-up is what we're looking at, again, to encapsulate some of what you said. We're looking to improve health outcomes by taking the base grant, block grant that we have right now, and I've coined the phrase, creating the Tennessee Shared Savings Plan, where the additional dollars are going to come from the savings that we've created, and hopefully putting forth some of those programs that Leader Lambert had mentioned before. It is difficult, if not impossible, to say what those will be because we've not been approved yet. So a lot of that is still, we've got a wish list, and I think it's a tremendous list that we've got some initiatives, but we get this in place and then we start that process. So can you mention as well, and I mentioned block grant has become the word, but this is really a modified block grant, more of a shared savings plan for Tennessee. If you could address that to a degree.
It is, and I know we kind of get caught up in these terms, but if you just really look at what the agreement is and what it's not, it's not a traditional block grant by any means, because it's not a fixed spending cap. It's a cap that's trended forward, and then we get adjustments for enrollment. So we've kind of used this term, a modified block grant proposal, and CMS uses the term an aggregate cap model. We've heard the term today, the shared savings model. And so it doesn't really matter what we call it. What matters is, what does it actually do?
Thank you. Thank you, Chairman.
Thank you, Chairman. Chairman Todd, you're recognized, sir.
Thank you, Mr. Chairman. I guess I want to summarize some things that are in the letter that CMS has sent the state, and if I mischaracterize anything or if it's out of context, I'd just like you to comment on that. If it's not, you can just say that's accurate, because I want to make sure I've summarized this appropriately. The state will use a budget neutrality structure bound by an aggregate cap on demonstration funding. It's not a block grant, as you just stated, but rather gives the state flexibility in operating its program under a defined cap by putting expenditures at risk based on both cost and population growth, and is consistent with existing CMS policy outlined in the budget neutrality policies for Section 1115. It also allows the state to appropriately manage cost within a fixed budget. And that's very important to us, obviously, on this committee. Up to 55% of any savings achieved may be earned by the state in the form of additional federal matching funds that can be reinvested in the state health programs. CMS will allow the state the discretion to make certain changes in the programs within parameters established without additional federal approval. It gives some administrative flexibility that may allow the state to be better equipped to respond to changes in demographics, economic conditions, or emerging public health issues without time delays in order to more effectively manage their Medicaid program, which I'm considering at this point with the pandemic, with a lot of people unemployed, COBRA running out with some individuals, we could see some changes that need to be made, and so I thought that was a real positive aspect of this. It gives us some flexibility to be mobile on that. Also, any coverage or benefit changes to existing populations covered are limited to those that are additive in nature, as has already been stated, and the state is not authorized to make reductions to its current approved coverage or benefit package without approval of an amendment. So that's another safeguard built in, and again, several of us have received comments from the public and certain organizations that maybe don't see the details of this, like what has been sent to us, and so wanted to make sure those things were on the record and are accurate. If you could just affirm that, please. Thank you.
Yes, that's accurate. You're reading, I think, directly from the CMS approval letter. So, thank you for making those comments.
Chairman Todd? All right. Members, any other questions for our guest, Director Smith? Chair Lady Hazelwood, you're recognized.
Thank you, Mr. Chairman. In a presentation that I sat through earlier that you made, you mentioned that whether we go forward with this process or not, our current TennCare program, that waiver is running out, and we will have to renegotiate with CMS, and that is a total unknown. We have, we have in front of us an offer, if you will, from CMS, where there are many unknowns has been addressed here in terms of how it will play out and exactly how much savings, because we don't know what the economy is going to do, if there's going to be a big run on TennCare, or a lot of people are going to be able to get jobs and get out. There are just so many unknowns. But can you just speak to, I guess, in terms of risk, we have a bird in the hand, if you will.
Yeah.
And then we have one in the bush that's out there that we would be dealing with if we don't accept this. Could you elaborate on that just a bit for us?
Sure, I'd be glad to, and that's a really good point. So our existing waiver expires June 30th of this year. So whether we go forward with this agreement or whether we do a traditional waiver renewal, we will have a new waiver. So we've got a really good deal in front of us that we can accept. If we don't go forward with this deal, then we're still going to have to negotiate a new waiver, and we're still going to have a budget neutrality cap. That's not something that is unique to this agreement that we're talking about. And that budget neutrality cap, by all indications, will be less than what we have negotiated with this agreement. So there's more risk there. Also, we've negotiated a 10-year agreement, and we are going to get credit because of our negotiations. We're going to get credit for $6 billion of accumulated past savings that are going to be available to us for the full 10 years. That means that if we exceed our cap, we have that $6 billion as kind of overdraft protection. We'll have it for the full 10 years. If we do a traditional waiver renewal, that will only be available to us for 5 years. So this agreement provides some real stability to our program, and I would argue that we have a greater risk with a traditional waiver renewal than we have with this, and we get no reward at all with a traditional waiver renewal, and we get a reward opportunity with this. So when you compare it against where we would be otherwise, to me, it's an easy decision.
Chairlady Hazelwood.
Thank you.
Thank you. Leader Camper.
Thank you, Mr. Chairman. One last question about inflationary costs. Did you all look at or compare what we would do if medical inflationary costs outpaces just traditional inflation?
Well, so what we can do is we can look at historic performance, and when we do that, so we're getting roughly a 5.1% trend rate, and that's on the aggregate. That's what's in the president's budget. Historically, if you look at our performance from 2015 to 2019, we've been slightly under 3%. 2014 to 2018, about 4%, but still pretty significantly below that 5.1%. If something were to occur and our trend was going to go up significantly, there's probably a couple of reasons for that. One is it probably means that we've increased enrollment significantly, and we've negotiated in this agreement a provision where we will get an adjustment to our cap if our enrollment increases. The other thing that might happen is we have some very unexpected economic condition. We're in a pandemic right now. If something similar to that were to happen in the future, then we could go and we could seek an adjustment. So we feel like we've got these built-in protections. And also, remember, it's a 10-year agreement. And so when we're talking about the shared savings opportunities, it may be that in 1 or 2 or a couple of the 10 years, we don't achieve shared savings. But overall, when you look at the life of the demonstration period, we feel confident that we will achieve those shared savings.
Thank you, Mr. Chairman. Thank you, Mr. Smith.
Thank you, Leader Camper. Any further questions for our guest, Director Smith? I'm seeing none, so without objection, we will go back in session, and we will go back to the sponsor. Members, any questions for our sponsor? All right, seeing none, are you ready to vote? All right, seeing no objection, we are now voting on House Bill HJR 18, moving on to full finance. All those in favor say aye. Aye. All those opposed, no. The ayes have it. HJR 18 moves on to full finance. Members, this does complete our business for today. We do have, I'm going to send it to Chairlady Hazelwood if she wants to make a quick announcement on full finance and when we will be meeting there.
Finance full will meet immediately, so any members who are not in the room, please hurry on down. As soon as we have a quorum, we'll begin our meeting. Thank you.
All right, thank you, and I see no further business, so without objection, we stand adjourned.